Today, we are going to be talking about one of the biggest problems I see in clinical dentistry, dental hygiene, all the things, and that is the incorrect calculation of cal in our dental softwares. So stay tuned. I'm going to talk about why this problem exists and what we can do about it clinically. All right, friends, welcome to the Grow RDH podcast. My name is Katie and I am your host. I am a dental hygienist from South Dakota. And this month, the month of April, is Perio month. And I am calling it Perio month because it is my birthday month. And so I am going to just enjoy the month of April by celebrating with talking about Perio. Perio is one of my favorite subjects, topics. I have been teaching Perio since 2014, and I work clinically in a population that has very high severe Perio. So it's just something I'm passionate about. I'm excited to talk about cal with you. It is, if you've heard, I've had a few podcast episodes about this issue, and I will continue to talk about it because it is something that I truly believe really muddies the water when it comes to staging and grading. And I think it's one of the reasons why, since the dawn of EHR, this just hasn't really been addressed. And so I'm hoping that by continuing to bring light to this issue, that hopefully some softwares might hear this and see the problem and see the change. I have brought this issue up, brought this forward to some softwares and kind of got some pushback. And that pushback is related to the true definition of cal, clinical attachment level, versus cal as in clinical attachment loss. And so we're going to kind of be picking this problem apart, and I'm going to be talking about what I think is the issue and what I think you can do as a clinician to make sure all of your perio charts are accurate. So I'm assuming while you're listening to this, you're not in the clinic, and that's okay. But what I want you to do is really go into whatever software system that you are using and kind of investigate this problem. I have talked to other perio educators that are out there. I have talked to other clinicians that are out there that are using a variety of different softwares. And what it sounds like is that this is a problem industry-wide, not just with one specific software. I will say that Dentrix seems to be based on feedback, user feedback. This does not come from the company or anything like that, but based on user feedback, Dentrix is actually the most customizable when it comes to the calculations in the software. And you can actually ask them in your organization to change this setting, and successfully organizations have had this change through Dentrix. So if you're a Dentrix user, props to you. And if not, if you are using a software that does this correctly, please reach out to me, Katie at Grow RDH, or throw a comment down wherever you're listening to this, Spotify or YouTube. Throw a comment down and let me know what software you use. Interestingly enough, I use a software that is kind of homemade. Again, I work for a state agency in the Department of Corrections, and when they went fully digital, they actually had software developers from the state of South Dakota. You know how state agencies work. They bid out jobs, and it was actually a homemade system that they modeled off of other, industry known softwares that did this. And what's interesting about it is this homemade software that we use does it correctly. And so I've just been using that for so long that I don't think I realized how badly current software systems do this, because I just didn't have the experience. I didn't have the clinical knowledge. It was very recently, within the past year and a half, we incorporated a new system. And I'm not going to say the name of the system you use because I don't want to talk negative about any one brand or company. I'll give props to the companies that do it well, Dentrix, but I don't want to talk bad about softwares that are maybe doing it incorrectly. But what I will say is that trying to incorporate that into a system, into a clinic, and realizing how poorly the softwares calculated cal really opened my eyes to this problem. And so then I started talking to other schools. I think what's interesting, what's unique about my situation is that I have to go into the classroom and teach the students how this theoretically works. So I teach them that, and then they have to go use this software that is kind of spitting out a calculation that is incorrect. Yet, in order to correct it, it's very time consuming and it's very tedious. And so it's really difficult for them as they are like, they're first learning how to use a probe, how to instrument correctly. So they have all of these hurdles that they have in front of them trying to learn. And then when they learn in a software that isn't doing it correctly, that makes it even harder because what they're learning in the classroom doesn't match what the software is doing. And that's really confusing. If you're learning something for the very first time and you have to use the software that doesn't match, it is very difficult. And so I think for me, this is really highlighted on a grand scale because I see the disconnect between theoretical, what we teach in the classroom, versus clinical. We're just used to looking at EHRs that look like this. We have to use our clinical reasoning or critical thinking, basically, to kind of take that software and be like, okay, well, what does that really mean? And we as, advanced clinicians can do that. And so we have a lot on our plate, right? We have 8 to 10 patients a day. We're doing all the things that hygienists have to do. And we don't really have time to go fight this big industry, this big organization and say, hey, you're doing this wrong. That's a fight that we really don't have in our bandwidth to take on. So I think the problem has been around for a while. The voices that are talking about the problem aren't as loud as the busyness of dentistry in general, if that makes sense. I don't think it matters. And I'll tell a story. When we were trying to incorporate this new software, I consulted multiple different universities, and I consulted with 2 periodontists in our state that are very supportive of the school, and they had a lot to say about this. Basically, what just kind of broke my heart a little bit was that when they get referral patients from anywhere, when they get referral patients into their office, they don't even look at cal because there's so much wrong with these systems that the cal is never accurate. And so they don't even look at it. And basically they said, if you can figure out a way to get this to work, great. And I said, I'm determined and I have a mission. And that mission is to get these organizations, these software management companies on the same page about cal level versus cal loss and why loss is the most important thing. Loss is what helps us stage and grade. Cal level really essentially doesn't mean a whole lot when you're looking at the context of a perio chart. So I'm ranting a little bit. What I want you to do, and I know if you're listening to this at home, that's fine. The next day that you go into the office. So if you're listening to this on the day it comes out on Friday, on Monday, I would love for you to go into your office and see what your software calculates for cal. Because what I think you'll find is that the cal line either automatically inputs the gingival margin as a value of 0, which automatically makes the cal level the same as the pocket depth. And that's a big problem because most of the time, our gingival margins are above the CEJ. If you're saying that the gingival margin is 0, that means the gingival margin is right at the CEJ and the full pocket depth is the full amount of loss, which is wildly inaccurate. And I think that this gets thrown by the wayside because perio charting already takes a lot of time and we know that we're short on time. So we don't go back in and adjust the gingival margins because it's very time consuming. So please, I challenge you, just go and see how your software is calculating cal in the first place. I think what's interesting to talk about or learn about is when you dive into the history of clinical attachment level and clinical attachment loss, what's interesting is that Sometimes in the research and in the studies that are done around this and the seminal sources of information about this, I think what you'll find is that a lot of the times clinical attachment level and clinical attachment loss are used interchangeably, which if you look in the original definitions, it kind of makes sense why this happened. But even in Gehrig, this is the periodontal text that I use. It is one of the reference texts for boards. It still is very confusing of how it's described and how you find it, especially when they're talking about, it's significantly above the CEJ or it's slightly above the CEJ. And that's taking into account that 1 millimeter of attachment. What I think is important to remember, you don't have to go back and review all of these things. What you as a clinician need to know is what is the amount of attachment loss. This is essential because that is what you're looking for when you are staging and grading. The clinical attachment loss, not level, is what is taken into account when you're looking at stage 1 through 4. So no matter what your software is telling you, you have to use your critical thinking to understand or determine if it's loss or level. And they're not very clear. So I want to kind of frame this around what clinical attachment loss is. Clinical attachment loss is essentially the detachment of the junctional epithelium from the tooth, and it's supposed to be attached right up to the CEJ. When you get detachment, you feel the CEJ is present, you know you have loss. Some of the software systems are automatically giving you a level. So if I have a 3 millimeter pocket, it shows 3 pocket depth and then 3 clinical attachment level, or that's what the softwares are saying it is. Now, if I look at that pocket and it says 3 millimeter pocket depth and then 3 millimeters of CAL, because CAL is what's used as the acronym, but then I have the next pocket that's maybe a 4, and I correct that as it's 3 millimeters above the CEJ, but it's 1 millimeter below. Now that tooth is giving me a CAL of 3. When I talked to the software about it, they said, well, that's the level. And I said, okay, so there's the problem. Therein lies the problem. Is in the same system, let's use the next pocket, for example. I might have a 4 millimeter pocket on that tooth, right? 4 millimeter pocket depth. Now, it really matters on a 4 millimeter pocket where the gingival margin is. If the gingival margin is 2 millimeters above the CEJ, that means it's the junctional epithelium is 2 millimeters below the CEJ, and that would give me a CAL of 2. So if I go in and correct the gingival margin on the 4 millimeter pocket and I have a CAL of 2, but the pocket right behind it has a 3 millimeter pocket with no CAL, but it automatically gives you a CAL level, therein lies the problem. That means I have on the same line an adjusted clinical attachment loss and a 3 millimeter clinical attachment level. Now, as a clinician who's been practicing for years, I understand that those are very two different things. But fundamentally, and as a student learning this, or as sitting down as somebody that didn't see the patient, I wouldn't be able to look at a perio chart and objectively know which pocket on that tooth shows true CAL, as in loss, or which pocket on that tooth shows 3 as in CAL, as in level, so it's healthy. There's no objective way to determine the difference. And this is a fundamentally bad problem. This is causing a lot of issues when it comes to offices trying to learn and implement staging and grading because these software systems are so messed up. If we have to continually look at that CAL line and know which ones are level and which ones are loss, that's very tedious. It's very difficult. If you sent that into insurance or you sent that to another hygienist who's never seen the patient before, there's no objective way to know the difference. So there's a couple different problems that I've seen, and the software systems can vary about what they're doing. The first problem is that they automatically put the gingival margin as 0. And this is when you're going to get A 3 millimeter pocket is 3 millimeters of cal. That means that that gingival margin value is automatically calculating to be 0. So if you think about that and you go back to your textbooks, what that actually means in terms of periodontitis, when the gingival margin is 0, that means the gingival margin is at the CEJ. And that also means that the whole pocket is lost. That is not the case. And if your perio chart is reflecting that, that is what you would assume. If I were to look at a perio chart and I saw 3 millimeters with a 0 gingival margin, that means that gingival margin's at the CJ, that means that whole 3 millimeters is lost. And I don't believe that in most cases, that is truly what's appearing clinically. What can also happen is that the values of the numbers are different. And like I said, the example of the system that I use in order to kind of correct this, they have the pocket depth value as a negative value, and it is very confusing, and it even makes the calculations going in incorrect. So there are a lot of problems. So what I'm going to offer you today is just some simple solutions. I would love to hear about your experiences, get into your perio charts, and let me know if you were able to figure it out or if you are able to cheat the system. So here is what I would recommend. If you have a software that is automatically putting the gingival margin value as 0, meaning that your cal value is the same as your pocket depth, it's an easy fix. You can go in and make your gingival margin the exact same as your pocket depth. That should cancel each other out, giving you a cal of 0. I know that sounds like a ton of work, but if it's a healthy patient, it shouldn't be. This means if you have 3s all the way across, or 3-2-3, 3-2-3, it's very easy. And you can kind of do this at the end of the appointment, or if you have maybe an assistant helping you, have them go in and just default the gingival margin to the same as the pocket depth. It means they're going to cancel each other out. The pocket depth should be a positive value, and any value of the gingival margin over the CEJ is a negative value. So if you have a 3 millimeter pocket, your gingival margin should be a -3. They'll cancel each other out, and that gives you a cal of 0. And that is the same equation that they use in the textbooks. That's what we're supposed to be doing. It's just that the softwares are automatically defaulting it to 0, so it's not. If you have a software that does not give you a cal automatically, your job is easy. Don't do anything except for adjust the gingival margins as you need to, as you see fit. So if you have a 3, just leave it. There's no reason to change it, right? If you have a 4, put in a -4, right? Because that's going to show you a cal of 0. And it's going to show that that 4 is all pseudo pocket. It's specifically important to do these on 4s and 5s. The reason, and I have linked an old podcast episode about this, I talked about this very early on in the podcast, but the reason this is important is because in those 4s and 5s, if I'm a clinician and I didn't do the original perio chart and I look at a chart that has a bunch of 4s and 5s, and the gingival margins are not fixed or are not adjusted, I'm not going to know, are those 4s and 5s actually pseudo pockets, meaning there's no cal, it's just swelling, or are those 4s and 5s those early stages of bone loss? It's really hard when they're 4s because that stage of periodontitis is not visible on the x-rays yet. That's the biggest gray area. So when they're 4, and you feel the CEJ, you know you have at least 1 to 2 millimeters of cal because you can feel the CEJ, adjust the gingival margin accordingly. So if you feel approximately 1 or 2, it's really hard at the initial stage, but you kind of have to assess, are you feeling the CEJ and how much of it are you feeling? This is an estimation. We don't have a probe down there. We can't see where the CEJ actually is. We have to go by feel. If you're feeling in a 4 millimeter pocket that the CEJ is present, adjust the gingival margin to 3 or 2. Now, if you have a 4 and you adjust your gingival margin to a -3, it will show 1 cal, and that puts you in a stage 1 perio. Very similarly, in a 5 millimeter pocket, if it's all pseudo pocket, adjust the gingival margin to be -5. That will show a 0 cal. If you feel the CEJ on a 5 millimeter pocket, go down with your Explorer, feel how much CEJ is present, and adjust accordingly. You might put in a 5 millimeter pocket and a 2 millimeter -2 gingival margin. That will show a 3. That would put the patient into a stage 2 periodontitis case. So this is why the gingival margin is so important. It is such an important piece of your perio chart. So as a birthday present to me, please consider this month or even this week, try auditing your perio charts. Try playing with the software so you understand how the calculations are being done and where those values are being pulled from. A lot of the times it's just a simple mathematical equation. That's what the software people do. That's what they know how to do. They can code, they can put equations in, but what they're missing is the understanding of what it clinically means for us. That's why we have to be critical thinkers and we have to adjust and show in our perio chart the true accurate picture of what cal is actually meaning. It's very confusing to have cal level and cal loss on the same chart. So make your charts the most accurate for staging and grading that they can be. Not only will this help you get your procedures covered by insurance because you're showing not only the pocket depths, but you're showing cal. But it will also help more accurately watch that patient from the initial stages of non-surgical periodontal therapy all the way through the maintenance because those cals are more accurate. If you do anything this week, please, as a birthday present to me, try to fix your perio charts. Let me know. I love talking about this, obviously, and that's why I chose it for my birthday topic. But let me know how it goes. Let me know how your charts calculate cal and what you do to fix it, or if you've tried to fix it. I would love to hear your thoughts and experience. Stay tuned for all the perio content. I have some really exciting things coming. Next week, specifically, we're going to be talking about overdiagnosing, and this also ties to cal, but also even before cal happens, looking at health and disease and why overdiagnosis happens. Week 3, we're going to be talking about the very important re-eval appointment. I know some offices do it, some don't, so we're going to talk about the benefits of the re-eval. And then finally, we're going to wrap up April with a really exciting guest, Noriana Pryor, talking about perio and perioscopes. It's going to be a great month. I'm excited to have you along with me. I'm excited to celebrate my birthday, talking with friends and talking about ideas and topics that I love and I'm passionate about. So stay tuned, and if you like this content or value it, please like, share, subscribe, send this to your office, and have a whole office team huddle about cal and about how you as an office can really calibrate and get on the same page about what you want your periodontal charts to look like. Have a great week, and I will see you on the next one.